I'm Anne Rancourt from the National Institute of Allergy and Infectious Diseases, part of the National Institutes of Health, and I'm here with Dr. Jonathan Mermin from the Centers for Disease Control and Prevention, our sister agency. Dr. Mermin, thank you so much for being with me.
And it's great to be here.
Thanks. And thank you for watching at home or at work or wherever you may be. We would love to take your questions and comments during this broadcast, so please leave them in the comments or just tell us where you're watching from, because we'd love to know. So we are here in Seattle, Washington at the Conference on Retroviruses and Opportunistic Infections, where CDC has just released new data on rates of HIV infection. Dr. Mermin, can you tell us a little bit about this?
Yes, well, we have some exciting news that HIV incidence, or the number of new infections, are down. We've had about an 18% reduction for the country as a whole between 2008 and 2014. And that includes some even larger reductions in some groups. So for example, among heterosexual men and women, we've had a 36% reduction, and among people who inject drugs, we've had over a 50% reduction in new HIV infections.
Wow, that's wonderful news. And have you been able to break that down further and look at other trends like geography within the United States?
Mm-hmm. Well, for about 36 of the states, we had enough cases that we could actually look specifically by state. And we were able to show for some states some dramatic reductions. So, for example, New York, Pennsylvania, Illinois, Georgia, and North Carolina have all had between 20 and 45% reduction in new HIV infections. And we've also seen, in general, reductions in most states throughout the nation.
That's wonderful. And what about looking by race and ethnicity in our diverse country?
Well, we've had some success and some continued challenges. African Americans have been a disproportionately affected group. Their rates of HIV have been about 8 times higher than white Americans, and for Latinos about 3 times higher than white Americans. And the rates among young African American gay men had been going up. What we've been able to do is stabilize that rate, but not yet reduce it. For African American women, however, in another study that CDC has recently published, we were able to show not only dramatic reductions of over 50%, but also reductions in the disparity itself. So the rate of decline was greater among African American women than other women.
That's wonderful. And what about age in general? You mentioned young Black Americans. What about other groups?
Mm-hmm. Well, we've seen reductions of about 18% among young gay and bisexual men between the ages of 18 and 24, and we've seen reductions in middle-aged gay and bisexual men. Where we continue to have challenges is in the group that I would call youngish, people between the ages of 25 and 34, where we've had an increase of about 25%. In addition, we've seen increases among Latino gay and bisexual men, a group that we really want to turn the corner on and start reducing the number of new infections.
And is this what you expected to see? Was this a surprise? How did it turn out?
Well, we had some inclination that from diagnoses over time that this might be occurring, but this is really exciting information to see the estimates of new infections go down. The other impressive finding is that in all 36 of the states that we do have data, not a single one of them had an increase in HIV infections.
That's wonderful. And so this type of analysis is really the bread and butter of what CDC does. Can you tell us a little bit about how you put this type of data together and how people know that it's representative of the country as a whole?
Yeah, so CDC has an HIV surveillance system in the nation, just like we would have one for typhoid fever or influenza, and we receive case reports of when someone's been diagnosed with HIV. And then what we have done for this conference is analyze the data using a mathematical model so that we could estimate new infections. They may be different because for HIV, it's a lifelong infection. So you could have been infected 5 or 6 years ago and be diagnosed this year. So we wanted to distinguish between when you were infected and when you were diagnosed. And what we presented today was actually data about new infections themselves.
And so we have some folks who are watching from some certain locations here in the United States, from Dallas, Philadelphia, and Houston. So thank you for tuning in. And Dr. Mermin, you've been working in this field as a clinician and a public servant since the 90s. How does it feel to have this kind of good news in an epidemic where we haven't always had good news?
I'm really hopeful. I think we've been able to turn the corner for the first time in 2 decades in reducing HIV infections in the United States. We know what we need to do. We have the tools to make a difference. That there's power behind HIV medicine. It both helps people with HIV live a long, healthy life, and it dramatically reduces the chance that they will transmit HIV to other people. And in addition, recent science has shown that if I take medicine on a daily basis, I can greatly reduce the chance that I will acquire HIV. It's called pre-exposure prophylaxis, or PrEP. And so those exciting new interventions really give us the ability in the nation to continue this positive trend.
Mm-hmm. We have the tools that we need now.
We do.
That's wonderful. And so let's talk a little bit about what the data for injection drug users and what this news means. So we have a huge problem with opioid abuse in the United States. How does this complicate efforts to drive down the rates of HIV acquisition for injection drug users?
This is a major concern for CDC in many communities in the United States. We've seen increasing numbers of people injecting drugs, not just heroin and methamphetamines, but also prescription opioids. And that puts them at great risk for overdose as well as infectious diseases like HIV and hepatitis. And we've actually seen increases in hepatitis C infection and hepatitis B infection due to drug use. There is a lot that we can do. First, we've had these reductions over the past few years in new HIV infections among people who inject drugs because we've been able to diagnose more and more people with their HIV infection, help them access antiretroviral therapy or HIV medicine so that it reduces the chance that they'll transmit to others. And we've also set up programs in many communities called syringe service programs, which are really comprehensive activities which help engage people who are currently injecting drugs to get into drug treatment, to access sterile injection equipment so that they don't get an infectious disease, and to get diagnosed for HIV or hepatitis and get the treatment they need. And combined, that can make a big difference in people's lives and help them stop using drugs.
And in the data that you're reporting today, there's a difference in the rate of decline between injection drug users and men who have sex with men. Can you tell us a little bit about the difference there and why we see that?
Mm-hmm. Well, your risk for HIV isn't just dependent on your risk behavior, but also about the prevalence of HIV in your community. So, for example, gay and bisexual men in the United States are 80 times more likely to have HIV infection. So if I have a new partner, that puts me at a much greater risk. So having more people diagnosed and knowing how to protect themselves has made a big difference in people who inject drugs and heterosexual men and women and some age groups and race and ethnicities of gay and bisexual men. But we still have more to do because the prevalence is so high. We need to help gay and bisexual men get diagnosed with their HIV, access pre-exposure prophylaxis or PrEP so that they can avoid getting it, and know how they can avoid getting HIV through other mechanisms so that they can be part of a community that slowly starts reducing the incidence or new infections as well as the prevalence or number of people living with HIV.
And so for folks watching the video who fear that they might be at risk of HIV infection, what's the one thing you'd like to share with them?
Well, I think the single linchpin for HIV prevention and treatment is testing. If you can get tested for HIV and you have HIV infection, you can access treatment, which will help you live a long, healthy life and will reduce the chance that you'll transmit to others. And the sooner you get on that treatment, the better it is for you. If you don't have HIV infection, you can talk to the provider about how you can protect yourself, including potentially accessing PrEP. So the single most important thing you can do is get tested for HIV.
Excellent. Dr. Mermin, thank you so much for joining me, taking time out of your busy schedule here at CROI. It's been wonderful chatting.
It's been great. Thanks,
Great.
Amy.
Thank you. And thank you so much for watching. For more information, please visit AIDS.gov.